rabies and Australian bat Lyssavirus post-exposure management, and some general travel vaccination updates. Let's begin by acknowledging the traditional custodians of the country across our region and their deep and enduring connections to land, water, culture, and community. I pay respect to elders past, present, and future, and extend that respect and a warm welcome to all Aboriginal Australians joining us this evening. And welcome everyone. Thanks for joining us. It's a cold Wednesday night. Just a few housekeeping points. If you feel comfortable with it, we'd encourage you to turn your webcam on so our speakers can see who's part of the webinar audience tonight. If you wouldn't mind, could you stay on mute unless you're actually asking a question, but you can also put your questions in the chat box and we can save them to the Q&A part of the presentation, which is at the end of each. Tonight's sessions is being recorded and the slides will be emailed to participants over the coming days. And lastly, as always, please remember to fill out your evaluation. So just a bit of background about our presenters. The webinar is presented in partnership with the Western New South Wales Local Health District and the Public Health Unit and the National Centre for Immunisation Research and Surveillance, the NCIRS. We're delighted to have two guest speakers, Dr. Victor Carey and Dr. Annie Huang. Victor is a local public health physician with the Western New South Wales Local Health District and Public Health Unit. He has extensive public health experience across New South Wales, including senior leadership roles in multiple local health districts. During the COVID pandemic, Victor worked with the New South Wales Ministry of Health as a Deputy Public Health Controller. Annie Huang joined the NCIRS in 2022 and is a GP and public health physician with additional training in epidemiology and qualifications in travel medicine. She currently works with the NCIRS Global Health Team, providing technical support to ministries of health in the Asia Pacific countries and in WHO-led initiatives on a range of immunisation related topics. So it's very relevant to tonight. So I think with that, I'll hand over to Victor. Thank you, Victor.
Thank you very much. It's great to be here this evening and a good opportunity to talk about a few issues. Firstly, bat Lyssavirus and post-exposure management. And I do this knowing Annie is going to follow me giving a comprehensive talk on travel vaccination, and she will cover rabies. But what I wanted to do is focus a little bit on the post-exposure prophylaxis, in particular in relation to bats, which is something that you may well be experienced in, or you might have a patient that presents following an exposure to a bat, and certainly from a public health unit perspective, where your partners in trying to manage this. I also thought tonight it was a good opportunity to briefly mention and update you on bird flu, the avian influenza situation across Australia and New South Wales in particular, and also on diphtheria, given the outbreak that's happening mainly in Central and Northern Australia, but potentially could have impacts here, and just to raise your awareness about that. So we'll kick off. Next slide, please. So as you're no doubt aware, both rabies virus and the Australian bat Lyssavirus are members of the same family and belong to the genus Lyssavirus. And all Lyssaviruses cause a similar illness known as rabies. Now, when we think about rabies, dogs are responsible for 99% of human infections, but there are other important reservoirs around the world, including foxes, monkeys, skunks, and raccoons. Australia is currently free of rabies in land-dwelling mammals. However, In May 1996, Australian bat Lyssavirus was detected in an encephalic black flying fox in Queensland. And since then, it's been identified in Australia in all four species of flying fox and one species of microbat. Next slide. It's transmitted via the saliva of an infected animal, introduced via a bite or a scratch, or by contamination of mucous membranes or broken skins. In Australia, human exposure to bats is common and increasing, with over 100 residents each year requiring post-exposure treatment in New South Wales. It's important to note that exposure to bat blood, urine, or feces is not considered an infection risk for Australian bat Lyssavirus infection. Next slide. The incubation period is usually 3 to 8 weeks, but I'll present a few cases and you'll see that that's not necessarily the case. Because the incubation period depends on many factors, including the wound severity, wound location in relation to nerve supply, proximity to the brain, the size of the inoculum of virus, and the degree of protection provided by clothing and other host factors. Next slide. The initial symptoms may include fever and sensory changes at the site of a preceding animal bite. Other reported prodromal symptoms include a sense of apprehension, headache, and malaise. That may lead then into one of the two clinical forms of rabies, encephalitic or paralytic. And it's important to note that rabies is almost always fatal. Next slide. Just going to talk about these 4 cases of Australian bat Lyssavirus infection, the only 4 cases. The first case occurred in November 1996 when 39-year-old Patricia Paget, an animal caregiver in Rockhampton, sustained several scratches from a bat. She reported to the hospital 4 to 5 weeks later for shoulder pain, dizziness, vomiting, headaches, fever, and chills. Whilst hospitalised, her condition rapidly deteriorated with slurred speech, diplopia, and dysphagia, and progressive weakness in her limbs. CSF samples grew no organisms. An EEG was performed and found diffuse encephalitis. She eventually fell into a depressed conscious state. By her 11th day of hospitalisation, she was fully ventilation dependent, non-responsive, and hypothermic. She died 20 days after her initial admission. Australian bat Lyssavirus was identified by PCR of brain tissue. The second case began in August 1996. 37-year-old female from Mackay was bitten on the finger by a flying fox at a birthday party while attempting to remove it from a child on which it had landed. 6 months later, following the heightened public attention from the first case, she consulted a GP regarding testing for the virus. Post-exposure prophylaxis was advised, but for unknown reasons she declined. After a 27-month incubation period, a rabies-like illness developed in November 1998. She came in with symptoms of fever, vomiting, shoulder pain, dysphagia, and muscle spasms. Her condition worsened after hospital admission, dysphagia increased, muscle spasms becoming more pronounced, and she became increasingly agitated. She became ventilation dependent and unable to communicate. On the fourth day of her hospital admission, tests returned with probable Australian bat Lyssavirus infection, and she died 19 days after the onset of illness. The third case occurred in December 2012 when 8-year-old Lincoln Flynn was scratched by a bat in Long Island. He became ill 8 weeks later with fever, anorexia, and abdominal pain. His condition worsened through his hospitalisation, aggressive bouts between normal behaviour and intense muscle spasms. He repeatedly needed to be intubated and sedated due to these spasms. This child died 28 days after the onset of symptoms in 2013 in Brisbane. And the fourth case, and most recent, was reported by the New South Wales Health Department in July 2025. In northern New South Wales, a man in his 50s was in critical condition with bat Lyssavirus after being bitten by a bat several months earlier. The man actually had received appropriate post-exposure prophylaxis, and it's a very, very rare incident of clinical infection following appropriate post-exposure prophylaxis. Next slide. So here we have the numbers of notifications that we've received across New South Wales in public health about exposures to potential rabbit animals. No, they're not all rabies, but just requiring post-exposure prophylaxis. 65% are from overseas and 35% are Australia. And you can see that dogs account for a large proportion, and it's monkeys and cats lesser. But megabats and microbats are becoming increasingly important in the types of exposures that we see. Next slide. So when you think about bat bites and bat exposures, what classifies as a potential exposure? Any bite, scratch, mucous membrane or broken skin contact with the saliva or neural tissue of a bat in Australia or elsewhere in the world. And then we go on to, of course, wild or domestic terrestrial mammals in a rabies-affected country. The principles of post-exposure management are, it's important to know the type of exposure, the severity, the age of the individual, prior rabies vaccination or antibody status, and that's very important. The details about the animal, the time interval since exposure, and whether that animal is available for testing. Next slide. So we categorize the types of exposures into category 1, 2, or 3, and this guides our post-exposure prophylaxis. So category 1 is touching or feeding animals, licks on intact skin, as well as exposure to blood, urine, or feces. Category 2 is nibbling of uncovered skin, minor scratches or abrasion without bleeding. And category 3 is single or multiple transdermal bites or scratches, contamination of mucous membrane with saliva or licks on broken skin. Next slide. And it's important to categorize these bites because then that determines what sort of exposure. Now, this is a very busy slide. I'm not going to go through this all. It's all available in the Australian Immunisation Handbook, which is a terrific resource. This is Appendix 1 from that handbook. But if we click the next slide, the important things are in a category 2 bite, in a non-immune person, someone that's never had vaccine, they will need vaccine as post-exposure prophylaxis, but no immunoglobulin. And if previously immunised, they'll need vaccine and no immunoglobulin. This is from a terrestrial animal overseas. A category 3 bite, non-immune, will require vaccine and immunoglobulin, but if previously immunised, vaccine but no immunoglobulin. So clearly, the benefits of vaccination prior to travel are clear because it reduces the necessity for immunoglobulin. Next slide. But when we look at, and again, yes, thanks. When we look at Lyssavirus, then if it's a category 2 or 3, they're grouped together now. If previously immunised, vaccine but no immunoglobulin, but non-immune for any category 2 or 3, they need both vaccine and immunoglobulin. Next slide. Giving human rabies immunoglobulin has to be infiltrated at a dose of 20 international units per kilogram in and around the wounds. So there is a formula which is available in the handbook. However, we at the Public Health Unit are your partners in this. So wherever you have a suspected bat exposure, call the Public Health Unit and we will actually work through that with you and we'll order the vaccine and arrange its delivery. With immunoglobulin, it's important that as much is given in and around the wounds, and the balance of that immunoglobulin is given IM at a distal site to where the rabies vaccine is administered. Next slide. Becomes more complicated if people have begun post-exposure prophylaxis overseas, and it's really important to give the public health unit a call because once again we will work through that. There's a lot of advice in the handbook as well as tables. It depends whether the person has had started on a cell culture vaccine or a nerve tissue vaccine, what schedule, because different schedules are used overseas. It might be intradermal, might be intramuscular, whether they've had rabies immunoglobulin. So give us a call. Next slide. On that number, the 1300 066 055, you call that from wherever you are, and that will go directly to your local public health unit. So if you're in Western New South Wales or Far West, you call that number and it will come through to the Western New South Wales Public Health Unit. Call us in any case where rabies or bat lyssavirus is being considered as part of a differential diagnosis, should immediately call us. We'll work with you, we'll order the vaccine and the immunoglobulin if necessary, and advise you of the schedule that you should use. Next slide. Okay, that was a bit of a whirlwind through Lyssavirus, but happy to take any questions. Next slide, please. Just a little bit about bird flu. In October 2025, H5N1 was detected on Heard Island, about 4,000 kilometres from mainland Australia. Since the 24th of June, there have been 17 cases as of the 20th of the 7th of H5N1 bird flu confirmed in Australia. 10 in WA, 5 in South Australia, and 2 in New South Wales. This is in birds, not in humans. So migratory seabirds. There have been no detections in poultry and no evidence of large-scale mortality events in any animals to date. It's been closely monitored, this situation, and assurances being provided to trading partners where necessary, because you can imagine the impact this could have if it got into poultry populations. It's important to note the current risk of bird flu to people in Australia is low. Next slide. In terms of the impact of this clade, which is H5N1 clade 2344B globally, hundreds of millions of poultry have been lost worldwide. The virus has spread to every continent, driven by migratory wild birds, and it's unprecedented mortality in wild birds, with mass die-off events reported across multiple continents. Mammal infections reported in at least 22 countries, affecting both terrestrial and marine species, with major impacts on food security, trade, and agricultural economies worldwide. Next slide. As I said, the risk to humans in Australia from all strains of avian flu is low. They do not transmit easily from animal to human, and human infections are very rare. Where it does occur, live transmission of live virus can occur by direct contact from fomite, inhalation, or ingestion. There's only been one human case of H5N1 in Australia, not this clade, but some time ago, who had contact with infected animals overseas. Human-to-human transmission of H5N1 with this clade has not been reported anywhere globally. Most cases have had direct exposure to infected animals or contaminated objects or environments. Next slide. I think the important take home is if you see a dead bird, don't approach it, don't go near it. And there is a hotline. And there's the Emergency Animal Disease Hotline, and that goes through to the Department of Primary Industries, and they have an emergency operations centre set up within New South Wales. It's actually at the Orange Agricultural Institute, and that will go through to the hotline, and they will take it from there. I guess from a general practice perspective, though, it emphasises the importance of seasonal flu vaccine, which we continue to recommend. Not that that's going to necessarily provide protection against any potential bird flu, but limiting the incidence of human influenza is an important thing because uh, one thing we do not want is the theoretical situation which could occur of co-infection with a bird flu and a human flu and potential genetic reassortment in that host, leading to something other than the current clade of bird flu. Next slide. A little bit about diphtheria. Next slide. Um, we're currently experiencing the largest diphtheria outbreaks in the vaccination era. As of the 6th of July, there were over 400 cases notified nationally. And bearing in mind, in the same period, we would usually see 11 cases. The notifications began increasing in October 2025 and a marked rise since February. The rapid increase in cases from February to April can be seen in that epi curve there. And there's been sustained transmission across remote Northern Australia and most cases in the Northern Territory and Western Australia, with some in South Australia now, just more recently. Next slide. Of those cases, about 65% are cutaneous diphtheria, and that's been the predominant manifestation across this outbreak with a median age of 28 years. However, 32% have been respiratory, and they were all locally acquired, median age 17 years. And of course, this is a greater public health concern due to droplet transmission and the potential for severe toxin-mediated complications. About 17% have been hospitalised, and one death has been reported with diphtheria identified as the probable cause. Next slide. The affected populations are remote communities, and 99% occurred in outer regional, remote or very remote areas, and 88% were residents of remote or very remote communities. Aboriginal and Torres Strait Islander peoples are disproportionately affected. 95% of cases have occurred within this community. Next slide. In response to the current outbreak, New South Wales Health has introduced additional funded diphtheria vaccination as follows. All Aboriginal and Torres Strait Islander people aged over 20 years who received their last diphtheria-containing vaccine more than 10 years ago are now eligible for a funded Boostrix. Aboriginal and Torres Strait Islander people travelling to recognised diphtheria outbreak areas are funded for a booster if they have previously received at least 3 diphtheria-containing vaccines and their most recent dose was more than 5 years ago. And those outbreak areas currently include the Northern Territory, Kimberley, Goldfields and Pilbara regions of Western Australia and far northwest South Australia. So I think it's important as GPs to review people's diphtheria vaccination status, in particular of Aboriginal patients, and determine whether they're travelling to those at-risk areas, because we do know that immunisation with a toxin-based vaccine will reduce the severe effects of diphtheria infection. Next slide. Thank you.
Thank you, Victor. Victor, we've got one question in the chat. Why contact DPI for suspected cases? So I'm thinking that's going back to...
Well, it's suspected cases where the bird is dead, not human cases. So this is our big thing at the moment. If you see a dead or sick bird, don't try and deal with it yourself. Record where it is, avoid it, and report it to that number so that DPI will usually get onto a local vet and they will deal with that sick or dead animal. But I'm not talking about human cases here. I'm talking about bird. bird cases.
So I think Gary was actually referring to the bats.
Oh, the bats. Sorry.
Sorry, Victor.
Well, no, I mean it's contacting the public health unity is the critical thing, not DPI. If the bat is available, for instance, it's a bitten a person, and we are able to have the live bat or the dead bat, then we can send it to um, have a post-mortem examination of that bat and determine if it was infected or not. And that will indeed reduce the need for post-exposure prophylaxis if the bat wasn't infected.
Victor, there are some large colonies of bats. I can think of one very big colony on the river in Dubbo. Um, is it correct that you can sort of walk through a path which sort of is underneath a bat colony and not be at any greater risk of
Yeah,
this?
I mean, it's exposure to saliva
Yep,
or neural tissue.
yep.
Yeah,
So, Victor, there's another question. For diphtheria, do we test with throat swab or serology?
throat swab. So a throat swab and clearly identifying on the request form that you suspect diphtheria, so culture for diphtheria, and because that also involves a PCR test for the gene expressing toxin, and that's critically important. If it's a skin lesion, and one of the complications with the skin lesions that are being seen is the classic diphtheria skin lesion is a punched out lesion with a grey pseudomembranous base, but we're often getting co-infections with staph and strep, so it's presenting a very complicated picture. Um, swab the lesion and also then a separate swab of the throat as well, and with the same advice on the pathology request form, identifying query diphtheria.
And Victor, there's one last one in chat. What was the vaccination status of those who had diphtheria?
I actually I couldn't tell that. I don't have that information. We do know that diphtheria uh, toxoid vaccine reduces the risk of severe illness, but it clinical infection can still occur with the bacteria, but it reduces the risk of toxin mediated kind of illness. Annie, you might like to comment.
Can I
Yeah.
just,
Oh,
I was just going to ask what the vaccination rate is like. Does this reflect a fall in herd immunity?
Uh, I, I think in the areas that we are seeing the increase in diphtheria incidence, immunisation rates have declined. Yes. We know in Western New South Wales the immunisation rates, especially in childhood, are actually quite good, getting up to 95%.
Yeah.
But I think also you see a reduction in immunity with age, and that's the important thing because really by 10 years post booster, you really there's a good argument for a booster at that point in time to increase the antibody levels.
Yeah,
Victor, just
I wanted to comment on that as well. So in we know that current childhood coverage for diphtheria is fairly good, 95 to 97%. But we have to remember that the vaccination schedule hasn't always been like this. And among older adults, we do see an immunity gap. We did a sero survey among people who donate to the blood bank, so samples at the blood bank. And among blood donors, I think it was only restricted to New South Wales. For people above the age of 50, only 2/3 were seropositive, had adequate levels of protection against diphtheria. So 1/3 of your older adults potentially aren't actually, have that immunity from vaccination.
Thanks, Annie. Victor, we've just got one last question. Does cutaneous diphtheria present with multiple lesions, or how big is a solitary lesion?
you can get multiple lesions, but classically, you'll see a single lesion, and that can vary in size. Yeah.
Thanks very much, Victor. And Annie, a little bit of travel medicine.
Yes, thank you. Did you want me to start sharing my
Yes,
screen
please,
now?
Annie.
Yep, okay. Sure. Yep, great. All right. Hi everyone. It's as yeah, it was mentioned in the introductions. I'm a GP myself, and I did my International Society for Travel Medicine training actually before I came to NCS, but it's good to be back among GPs and to be giving this talk. So I'd like to acknowledge that I am presenting to you from Daruk country, but this beautiful picture that was commissioned by NCS actually comes from Western New South Wales. So we do, have so it's fairly fitting for tonight, and I do want to acknowledge all the traditional custodians of all the lands that you are on as well, and the elders past, present, and emerging. So tonight I will try my best to cover within the time. I'll talk to you very quickly, firstly, about a clinical case that I actually did see, even though it seems, very, very far-fetched, but it did happen to me. And then just give you a general approach to vaccination for travel, and then cover a few specific diseases that you may want to consider and a few other general considerations. So I'll go straight to the case now. So as I said, this happened to me on a Saturday at a clinic that I was working in that was only open on Saturday mornings, wasn't open on Sundays. And this 35-year-old male wanted to see a doctor today, and we managed to fit him in to 10-minute time slot only. So this patient had been at the clinic since birth, but hadn't been visiting very recently, as many 35-year-olds tend to, as you know. So there wasn't enough time, being a walk-in, to pull out the paper records from his childhood. But we kind of knew that his mother, had some strong ideas about vaccination, and we really thought that he's probably completely unvaccinated. And I must say that this actually happened back in 2019, where we really didn't have that instantaneous access to his immunization history statement through the air portal that we would have now. But we knew that, as far as we knew, he wasn't on any medications or comorbidities, and of course we also confirmed this with him when we took his history. And he basically told us that he was traveling to Kashmir that following afternoon, and he was wondering whether he needed to get a vaccine or not. And for those of you who may be familiar, Kashmir is this far northwestern corner of India that is shaded in because it is recognized as a conflict zone. The borders, as you can see, depending on who draws the borders, not very clearly defined, but it's high altitude, home to these beautiful lakes. For those of you, so some of you may have even been there yourselves. So it was actually going to be his first international trip ever. And this was his itinerary. He was actually attending a work colleague's week-long wedding festivities, which is why he decided to go there out of all places on his very first international trip. And he was going to spend about 2 weeks there. He was going to stay for a little while to do a bit of tourism as well. And it was all organized for him by this colleague's family. There was going to be a private houseboat. And apparently there were also opportunities to participate in adventure water sports. And he was very uninformed and unprepared on his very first international trip. He wasn't actually exactly sure where Kashmir was. He just knew it was in India somewhere. Managed to get a visa only about 2 days ago. Didn't really think about travel insurance, and he was just told that his colleague, his family, their family was just going to take care of him when he was there. And he actually didn't know about having to pay for travel vaccines. He just thought that vaccines are free. You just walk into a GP's clinic and you get vaccines. And he kind of had very limited budget. He had already spent most of his trip money on the trip already. So yeah, this diagram represents me going, oh my goodness, all these things that I need to talk to him about besides vaccination. There are obviously lots of vaccination related issues, but just general other things like seeking how to seek healthcare overseas. This thing about travel insurance, food, water, general hygiene. Of course, Kashmir is at altitude, having to talk about altitude sickness. And then general safety in terms of the local political situation, road and traffic safety. He's going to participate in extreme water sports, so talking about that. And then animal bites in general, not just rabies. Other infections related with water exposure, for example, leptospirosis. And then what he needed to pack in terms of basic first aid kit, basic medications. There's a whole lot of other things that I've kind of taken off the list because I also didn't want to overload you when tonight was about travel vaccination. But also I could also see that I was going to overload him with information as well. So I also didn't want to give him too much because I could see that his brain was also starting to become a little bit like that. But in terms of vaccination issues, clearly many things are addressed. He's completely unvaccinated and also very poorly informed or misinformed about vaccination, given his kind of family, opinions about vaccination. He was very apprehensive. He was too scared to get more than one vaccine at a time. So he really went, I'm only prepared to get one needle today. I had a 10-minute consultation on a Saturday morning. I really didn't have the time to really sit him down and have that vaccination talk about the safety of vaccines, about the safety of co-administration. Um, and of course, I could see that there was an opportunity to maybe engage him in catching up on some of his other vaccines after he returned. So if he had a good experience this time, I'd have a better opportunity to then kind of talk to him after he returned about, how about getting all of your other vaccinations in. And also very practical considerations. He was departing in just over 24 hours. So we didn't really have that much in our clinic vaccine fridge. You'd have to go to the pharmacy to purchase, to bring it back. And we only had one community pharmacist just up the road, and this was kind of on the outskirts of Sydney. I wasn't really sure what was in stock. And of course, he wasn't really prepared to pay for it anyway. So, if I told him, oh, this vaccine was going to cost him this much money, he might have just, taken the prescription and not come back and not have, not get it filled. And of course, he was also not that motivated to get himself vaccinated. So I couldn't also suggest, oh, maybe you can get more at the airport clinic. So those are all of the constraints, and I will tell you about what happened later. I'll keep you in suspense now, but I guess I'll firstly talk to you about travel vaccination, and then I'll come back to the story. So just in terms of general approach to travel vaccination, this is, my take on that typical meme that you may have seen floating around, where I think what patients think I do is just look at a map of the world and go, okay, for this country, you need this vaccine, a very kind of one-to-one correspondence, country vaccine. What sometimes I think my colleagues think that I do in terms of the questions that I get asked is that they think that I have this crystal ball where I can predict that, oh yes, this patient will be bitten by that one mosquito carrying dengue on day 12 of their trip or something. But what I really do, and so I've put here the triangle, is to really think about, and you've seen many kind of triangle-based algorithms and frameworks, and I'll add another one here to think about travel vaccination also in terms of this kind of triangle of patient factors, destination factors, and activity factors. But then this is the other framework that I have in mind when I talk to patients about travel vaccination. And this is courtesy of Dr. Sarah McGuinness, who is currently one of our ATAGI members, but has been working in travel vaccination for a very long time. And this is her personal diagram. I don't think she's published it anywhere, but she was very happy to share it with me. That you kind of want to think about the duration of protection that you get from a vaccine, and how effective it is, or how much of an immune response it might give you, and kind of think that for the vaccines that give you lots of long-term protection and also generates a very good immune response, to think of that as long-term investment. So not just for this particular trip, but also for other trips that a patient might go on in the future, but also maybe also occupational risks as well. So for something like MMR, for example, especially if they're a healthcare worker, it's an investment not just for their travel, but also for their occupation. Or for things like yellow fever, it's just one shot for life. Or hepatitis A particularly is one shot that where so sorry, if you get your two hepatitis A doses, that then you're at lifelong protection. So going into each of these three kind of corners of the triangle. So firstly, thinking about patient factors. So you'd want to consider their age, sex, medical history, vaccination history, occupation. Like I said, sometimes vaccines might also protect them in terms of their future jobs. Health literacy, and what I also coined travel literacy. So how good are they in terms of being able to seek medical care when they're overseas? And this is maybe beyond just being able to seek medical care normally in Australia, but being able to navigate a completely different healthcare system, being able to figure out what to do with your health insurance. So you might have purchased health insurance, but do you know how to use it? But also there are also very different cultural ways for care seeking. Patients might interact with doctors very differently in different sectors in the world, where maybe it can be a lot more paternalistic, where what the doctor says, you get, and you can't really have that room for argument. So how are you able to advocate for yourself in those settings? So that's kind of part of the broader kind of travel literacy, not just health literacy. But of course, health literacy is also very important in terms of where do you get your information overseas. Do you kind of Google Australian websites and hope that you can extrapolate to wherever you are? So all of this is very important in terms of me considering whether or not to offer a vaccine to a patient when they're traveling. But also who else is traveling? Because sometimes you get these scenarios where mum will bring in her two kids and go, this is child A who's 2 years old, this is child B who's 5 years old. We're going to this or that destination. What vaccines do they need? And you kind of have to go, well, mum, maybe you also need vaccines. So don't forget that as well. So making sure that you do you do ask that question as well. Then there are your special patients when we're thinking about patient factors. So young children, pregnant breastfeeding patients, immunocompromised, people with significant comorbidities or multi-comorbidity, your patients who are traveling for, who have special occupations, so military or peacekeeping workforce, humanitarian aid workers. And also your volunteers. So sometimes actually your volunteers, especially people like your medical students on elective, or you're a high school student on, your special kind of high school trips abroad, they may actually be at higher risks because I guess if you're traveling overseas for MSF actually has special mechanisms for taking care of you. But if you're a high school student traveling on like a philanthropic trip, you're quite often what I hear is that teachers go, "Oh, you go and talk to your GP. We're not, responsible for your medical care." So what happens when that child is overseas? That teenager is overseas, and the teacher goes, "Oh, I don't know much about medicine." So you've got to really make sure that they're aware of what to do, that they're adequately and appropriately covered with vaccination. Then thinking about destination factors, so that's the another corner of that triangle. So making sure that you do take a really good travel history, a detailed itinerary that includes cities and regions. Sometimes at NCS we get asked for advice, and we get emails saying, "Oh, the patient's traveling to Africa." And we kind of go, well, that's really not detailed enough for us to offer vaccination advice. Where in Africa are they going? We're not the US where we think that all of Africa is one country. We know better than that. So please take a slightly more detailed history. And then also ask about any specific high risk spots. So if they go to Bali, are they planning to go to a monkey temple, for example? And then how long are they staying for? Whether they're going in the rainy season or dry season? Are they going to urban locations only, or are they going to be traveling to rural and remote locations? And then if they are going to be at a remote location, what will the access be like to healthcare? Can they kind of get transport out of that remote area very easily? Like if there's any sign of meningitis, for example, can they go to a hospital as soon as possible? And maybe that's a discussion with them around the meningococcal vaccines. And then any likelihood of detours or unplanned side trips? Are they going on a very regimented package tour, or are they likely to, go off on a jungle trip on a whim, which happens when you're traveling. You may have the best planned trip, but maybe all of a sudden you'll see something, that you're interested in when you're in country, and you decide to forego your existing plans and go somewhere that's actually very high risk. And then special destinations. So airplanes, especially long haul airplanes, can be considered a destination on their own sometimes. And then cruise ships are a little bit different from other destinations with their own risks. And then things like farms, wilderness areas, caves, waterways, and also healthcare facilities. So if you're talking to someone who's going to be traveling to volunteer in a healthcare facility, you've got to think about, are you going to be volunteering in a TB ward, for example? Are you going to be volunteering in a very high risk kind of setting? Then thinking about activity factors, so thinking about eating and drinking, are you going to be visiting friends and family, and are you going to be eating home cooked foods? Are you going to be eating kind of street foods, for example? Accommodation, are you going to be staying in someone's house? Are you going to be staying in an air-conditioned high-end resort? What kind of transport will you be taking? Are you going to be on an organized tour, or are you going to be kind of making decisions on your own? And this acronym that's used fairly often in travel medicine, VFR, visiting friends and relatives. VFR travelers are actually at a much higher risk in many regards, in that if you're visiting your friends and relatives, sometimes you've got to follow what your friends and relatives are doing, and you don't have as much of a say in kind of going, oh no, I won't eat that food. Sometimes you can't really refuse something that your auntie has spent 3 days kind of cooking for you. And sometimes you also think you're under the impression that you're safe because you're with family, when really it's been 20 years since you've been back there, and you've lost some of your childhood immunity. So there are some special and specific risks that you've got to consider. And then other special activities, so action adventure sports, mass gatherings and pilgrimages, humanitarian work, medical cosmetic tourism and sex tourism, very specialized types of tourism that obviously exposes you to bloodborne diseases where I know that the only VPD, vaccine preventable diseases, among those is hepatitis B, but as part of your bigger kind of travel medicine risk communication talk, you may want to talk to them about some of these other infectious diseases risks as well. So those are all the different things that are around that triangle, but then there are also additional VPD related discussions that you may want to have in your pre-travel consultation. So additional precautions around food and drink, mosquito bite avoidance, being careful around animals, road safety, travel insurance, and taking medical and how to seek medical assistance overseas. So these are all of these different discussions that you may want to have as part of your broader discussion around what should you do, what vaccines should you have, and also what your patient tells you around all these other factors also guides you in terms of how you want to consider which vaccine to recommend and which you may kind of go, well, this is kind of at your discretion. So now going into the actual vaccines themselves now. So the first thing to remember is don't forget that your NIP vaccines also cover you in travel settings as well. And so when I'm talking about some of these NIP vaccines, I've set them up in this kind of slide setting where on this side of the runway, this side of the flight, I've got your Australian context, but then on the other side, I've got your international context. And sometimes what we see in Australia for a particular VPD that's covered by our NIP, and sometimes our NIP in Australia covers for a disease in a different way to Australia than how the protection that I might give you in an international setting. So diphtheria, Victor's already covered this already. He's covered the cases so far. And so the handbook specifically also gives you guidance for travelers as well, in addition to what to do for the current outbreak. If you're thinking about traveling further afield, not just interstate, but internationally, these are your guidance. This is your guidance for getting DT boosters. And also New South Wales Health has also mentioned diphtheria antitoxin as well as another thing to consider. And I wanted to bring this up because I want to tell you that in an international context, there is a global shortage of diphtheria antitoxin. So this is not just an Australia-specific issue, but internationally, that there are several. There's a large outbreak at the moment of diphtheria currently in sub-Saharan Africa with 2,000 deaths. So a huge outbreak happening there, and there is a global shortage of the antitoxin. And there's 4 manufacturers of diphtheria antitoxin globally, and of course one of them is in Russia, and Russia is currently not willing to share its diphtheria antitoxin with the rest of the world. So one thing to really think about when you're counseling travelers. Then thinking about flu, so Australian context, and Victor's touched a little bit about bird flu, but just regular seasonal flu as well. Just to make sure that you're aware of the handbook guidance, that there's a little bit of guidance on travel as well for the flu season, that they are recommended to receive a flu vaccine. Internationally, travelers at highest risk of getting the flu are large tourist groups, especially those that include older people, cruises, mass gatherings, and pilgrimages. And you may also want to consider the timing of flu seasons overseas as well, especially in the northern hemisphere, but also in the more tropical zone where flu season is year round. So consider giving a second dose of flu vaccine if someone's traveling late in the flu season to the northern hemisphere or to the tropical kind of belt around the equator. So this is a diagram that's often used in terms of the relative risks of travel, and So the higher up in the diagram, the higher the risk, and the lower in the diagram, the lower the risk. And this is for travelers from kind of high income countries going to lower and middle income countries. And you can see flu is right up there in terms of your risks of travel acquired illness, where some of your other illnesses are less likely, but for things like rabies, it's still fatal. So even though you're less likely to get rabies when you're traveling compared to getting the flu, you still also want to think about what the potential outcomes may be when you're counseling the traveler in terms of travel vaccination. Then go to hepatitis B. So hepatitis B is recommended for travelers to Hep B endemic areas who may be at increased risk. But also thinking about international travel, it's not just the endemic areas, but also there are travelers who may be traveling for medical or cosmetic tourism purposes, or go to undertake activities that may be at higher risk of also concomitant intravenous drug use. So, for example, attending lots of music festivals, sex tourism, also humanitarian workers or people traveling to work in healthcare fields, making sure they're up to date with their Hep B as well. But then there's also action at adventure sports. So just to remind you that in some lower middle income countries and also low income countries, the WHO guidance for basic screening of blood products is not followed. And so you don't want to be in a situation where, as part of action and adventure sports, you sustain an injury that requires a blood transfusion and you aren't adequately covered against hepatitis B when that's easily preventable. So that is one reminder to everyone. Then to measles. So looking at measles in an Australian context, clearly we do have overseas acquired cases of people bringing measles back when they've been traveling. And just to remind people, of course, you've probably been reminded several times recently that before 1966, we haven't had that the same measles program that we have today, and so there are immunity gaps among older adults as well. And then in terms of the global situation, it continues to be quite concerning in terms of the global measles immunity gaps and the cases globally. So 180 of the 194 WHO member states actually reported measles cases last year. And so you may not be aware that there's a recent change in the Australian Immunisation Handbook where infants travelling overseas, so anywhere overseas, previously said infants travelling to high risk countries, that's been changed now. So it's just any infants travelling overseas may receive the MMR vaccine from as young as 6 months of age after an individual risk assessment. So this is a conversation that you can have with any travellers where they have young children to go, well, if they may be at higher risk of measles exposure overseas, and so we could give you an extra dose of the measles vaccine from as young as 6 months of age. But remember that if that first dose of measles vaccine was given under 11 months of age, it does need to be repeated again after the infant reaches 12 months of age. So it's an extra dose, not instead of the current 2 doses. And then meningococcal disease. So in Australia, we have mostly men B, a bit of men Y, and we've got these peak age groups. But the handbook does, for travellers, it does say, travelling to areas where meningococcal disease is more common, especially to mass gatherings, you're recommended to receive the men ACWY vaccine. The international travel context is that many of you may be aware of the meningitis belt in Africa, as you can see here, where it's the area of highest incidence of meningococcal meningitis globally, classically men A, but the epidemiology is actually changing recently because of increased vaccination. But you also do want to consider for any mass gatherings, and certainly for the Hajj pilgrimage in Saudi Arabia, you actually need proof of vaccination for your pilgrimage visa. But also think about other crowded settings like backpackers on working holidays, where at nighttime they may be accommodated in fairly cramped settings, and they are quite often in that 15 to 24 age group as well. But also, as I mentioned before, if someone's going to a remote location with difficult access to healthcare, you don't want to be unvaccinated and potentially have meningococcal developing when the next evacuation flight might be a week away. So that's also a setting where if someone were to develop meningococcal signs of meningococcal meningitis, you want them to be able to access healthcare immediately. Then thinking about polio, so in Australia, of course, we are polio free, but there are many countries, including several in our region, that are still detecting polio. So mostly environmental detections. For example, our nearest neighbor, PNG. And globally, it is still considered a public health emergency of international concern. So make sure that for international travel, people are still up to date with their polio vaccination. Then tetanus. Well, we have very few cases of tetanus in Australia, of course, but travellers to countries where health services are difficult to access in a timely way do consider tetanus vaccines. And of course, travellers are actually at a much higher risk of injury. They're in new surroundings. They're undertaking new activities. Like when I was saying to people that when you're traveling in certain countries, sometimes even the stairs, the steps in a staircase are cut for people of a different leg length and different height, and people fall over or carrying heavy luggage, so they do tend to injure themselves a bit more. And there is a long-standing periodic issue of global shortages of human tetanus immunoglobulin. So you do want to make sure that people are vaccinated so that they are up to date with their vaccine, so they don't need to access immunoglobulin. And then COVID, the global situation continues to change, but new variants are continuing to emerge. So just making sure that people are up to date with their boosters before travel. You don't necessarily need to go to a special effort of recommending an extra COVID vaccine dose, but just if people are due for boosters, just get the booster before they travel. And then moving on to slightly more exotic vaccines, as I call them, maybe not the most technical term, but just thinking about vaccines like cholera. The way that I've set up these kind of more exotic vaccination slides, so that I've kind of given you the age groups. So the green are the ones where it's clearly indicated, and the kind of reddish orange ones are contraindicated. You'll kind of see the yellow. You'll see some yellow in some upcoming slides where it's kind of considered for special groups. So it's kind of a discretionary age group as well. And I know there are pharmacists in our midst, and I've given you the New South Wales pharmacy vaccination policy as well. So for cholera, thinking about our triangle, so in terms of patient factors where you might want to recommend vaccination, where someone might have a high risk comorbidity, and you can look that up in the handbook, or humanitarian aid workers. Destination factors are if you go to a humanitarian setting or countries where cholera is actually detected, so some of these darker colors. Otherwise, I really wouldn't necessarily use a cholera vaccine for travel. And then activity factors, so humanitarian aid work, or people who maybe have less control over food and drink choices or preparation, and they're going to some of these countries. But really, the main thing is to really educate on safe eating and drinking when traveling. Then hepatitis A, again, educating on safe eating and drinking, but also just remembering that having that second dose within 12 to 36 months will give you lasting immunity as well. So even if people come back and get their second dose, then they don't have to worry about hepatitis A for other travels further down the track. Lots of different types of vaccines available have kind of given you kind of the different age groups. But patient factors, high risk comorbidity or occupational risk factors, destination factors. Actually, so for me, I actually kind of so hepatitis A vaccine is one of my favorite vaccines, if you can call it that, in that, as I mentioned, 2 doses gives you lasting immunity, and it's a fairly safe vaccine to give, and it protects you in a range of different lower middle income country settings. So if someone's going to be traveling, not just for this trip, but also in longer term, it's one of those that's high up in your investment diagram before. So I tend to go, well, if you don't have hepatitis A, just get it. Like it covers you not just for now, but also for later as well. But high risk activity factors are visiting friends and family, or less control again over food or drink choices and preparation. Then JE, I know that I'm talking to Western New South Wales, where so that there are some high risk areas where you may also even want to, people are vaccinated already, or you may want to consider vaccination for local factors as well as international travel. So patient factors, so as I mentioned, residents of high risk areas in New South Wales, where it might cover them for daily life, not just for travel. People who are maybe more prone to mosquito bites. So you know that there, this is anecdotal and maybe not yeah, it's very hard to do research on this, but we do know that some people just get bitten more for whatever reason, or people who are just less meticulous about other mosquito bite avoidance measures. So really don't put on the insect repellent. Also, destination factors. So Japanese encephalitis, really mostly what you would consider for Asia, but including PNG, but apparently eliminated in Singapore, and we hope that it stays that way. Also, longer stay. So usually I use the kind of a month as a rough rule of thumb, to go, well, if you're only going to be traveling for less than a month, then maybe you wouldn't necessarily bother with JE vaccines. But if you go to rural areas, if you're traveling during the wet seasons, then I'm more likely to recommend JE vaccination. Other activity factors like long periods of outdoor activity, not sleeping under mosquito nets or air conditioning. If you're going to be doing activities that puts you in proximity to pigs and other water birds as well, remembering that Imajev can be given intradermally in times of vaccine shortage, and this is from a piece of research that we at NCS conducted in Western New South Wales. So some of you on the call may have even been involved in recruiting patients for us or reviewing patients for us. So this is thanks to Western New South Wales that we've got this piece of recommendation. But also remember to educate people on mosquito bite avoidance strategies, because it can protect you against so much more than just JE. Then Mpox, so patient factors are gay, bisexual men who have sex with men, sex workers or sex tourists, people with HIV, and also laboratory healthcare humanitarian workers. You may want to recommend the vaccine. Also, high or medium risk contacts may be recommended for post-exposure prophylaxis. Destination factors. So this sit rep changes all the time. So I haven't put up a map because it is quite rapidly evolving still. So go and check out the sit rep for countries with circulating Mpox virus clade 1. Then activities and factors. So maybe if you really go to parties and festivals where there could be risky activity or sex tourism, healthcare, humanitarian work, high risk laboratory work. So remembering that if you're working with a virus or pox viruses in a laboratory, you're also at high risk as well. Then moving on to rabies. So Victor has very kindly already discussed post-exposure prophylaxis. So as he mentioned, I'll discuss pre-exposure prophylaxis a little bit. So patient factors for people who are at higher risk of rabies are young, ambulant children. Remember what Victor said before about body site and how quickly the vaccine, the virus, travels to the brain after you're bitten. So young children tend to be bitten because they're shorter, tend to be bitten especially by dogs on the face or in the upper body, and so they have a much shorter incubation period. People who are newly arrived at the destination are unfamiliar with the lay of the land, tend to be unaware of the local dog situation and tend to be bitten more. I've put here unpatient factors, so people who are less likely to be bitten. We know from our experience as travel medicine practitioners that people who've been bitten before, who have gone through the rigmarole of having to get rabies post-exposure prophylaxis, tends to be that old saying that if once bitten, twice shy, it totally applies to rabies, where people who've been bitten before don't tend to be bitten again. But also seasoned travelers and travel medicine staff, they don't tend to get don't tend to need rabies prophylaxis. And so this really brings me to the point that one of the most important prevention strategies is educating people about animal bite avoidance behaviors. Because when people know, they don't get bitten. So really make sure that people know about what the risk of getting bitten are. Don't play with stray dogs when you're traveling to a country where rabies is endemic. Then destination factors, so places with poor stray dog control, vaccination, places with poor access to rabies immunoglobulin. What Victor said before, that when if you get a high risk animal bite, and you already have your pre-exposure prophylaxis in terms of a vaccine, then you don't need immunoglobulin. And there are many countries globally where they actually don't have access to immunoglobulin, or sometimes they may have access to equine rabies immunoglobulin only, which is a little bit less effective than human rabies immunoglobulin. So you don't want to be in that situation where someone has to be evacuated, has to be flown home to Australia to be able to access immunoglobulin. Then, of course, specific locations and monkeys. So if they go to a destination where they're going to be encountering lots of monkeys, you do want to counsel them against rabies vaccination, but don't forget the dogs as well. Then activity factors, especially if people are traveling specifically to interact with animals, you really want to think about rabies vaccination. But also your joggers and cyclists. You may have seen videos on YouTube, or you've seen travelers yourself with your own eyes, or you may have experiences yourself even that packs of stray dogs in many villages like to run after. They like to follow joggers and cyclists as well. So that could potentially be a high risk activity. And what we mentioned before, pre-exposure prophylaxis reduce the need for immunoglobulin post-exposure. Also, watch out for some updated immunization handbook guidance. So this October and November, actually, handbook rabies chapter will be updated. I'm not allowed to tell you more because ATAGI is actually deciding on the exact wording next week. So I don't want to preempt anything, but we do know that updated wording will be published in this October and November. So there will be new guidance coming. So in terms of vaccination schedules for pre-exposure prophylaxis, these are the schedules that the Australian Immunisation Handbook recommends using. Although if you're not comfortable with intradermal, don't do intradermal, do intramuscular. And I won't, in the interest of time, I won't go into this in too much detail, but just to say, as Victor mentioned, I will reiterate, please, if there are bites sustained overseas, please contact the public health unit for advice on post-exposure prophylaxis. Also, when you deal with return travelers, ask about the body site of vaccine administration as well. Intragluteal vaccination is not accepted. We actually don't count the doses administered into the buttocks. So make sure that you ask them, where did they give you your vaccine if people did get a rabies vaccine overseas. And as I mentioned before, immunoglobulin received overseas may be human or equine. And so try to see if you can find out from the traveler who may have taken a picture of the box or the product that they were given. Then moving on to TB. So we really only recommend TB vaccination mostly for children under 5 years who are traveling to an endemic setting. unless they're high risk lab or healthcare or humanitarian workers, which is why this kind of age group is yellow, because there are some cases where you may want to give a BCG vaccine to people above 5 years of age, but not many. And then destination factors, so countries traveling, if people are traveling to countries with a high incidence of TB, and or staying in crowded conditions, visiting friends and relatives where you may have lots of family members crammed into a crowded accommodation, or high risk healthcare laboratory work, as I mentioned. So the BCG brands currently accessible in Australia are not actually registered by the TGA, so you can't get this through pharmacies. You've got to actually refer people to TB clinics to get BCG vaccines. And then typhoid vaccination. So the two vaccines that we have in Australia, polysaccharide and oral vaccine, the conjugate vaccine, that's actually much better than these two that's not available in Australia. So if someone is actually particularly motivated, you could go and get the typhoid conjugate vaccine when you arrive in your destination country if you really want it. But I know that most travelers, when they get to their new country, don't typically go and track down the vaccine as their first priority. So patient factors, so military, lab workers, food handlers are at higher risks. Destination factors, typhoid endemic regions. The Pacific often get left out, but there are actually large outbreaks that sometimes happen in the Pacific. Also countries where antimicrobial resistance is an issue. So this is Pakistan and India in different colors here, where actually lots of travelers bring back highly antimicrobial resistant typhoid back into Australia, and our infectious diseases physician colleagues then have to deal with that when that comes back to Australia. Longer stays means that you have more encounters with food and drink that may kind of expose you to typhoid. Also settings of poor sanitation and hygiene. Also visiting friends and relatives where you may have typhoid carriers in the family, and you have less kind of control over refusing food and drink from your family members who may be cooking for you, who may inadvertently be carrying typhoid. Then yellow fever. Yellow fever is the subject of many, many questions to the New South Wales Specialist Immunisation Service that I'm part of. So there are two destination factor boxes on purpose, because there are two types of destinations. There are destinations where you have legal requirement to get the vaccine, and there are destinations where you're actually at higher risk of yellow fever. And these two lists don't always neatly match up with each other. And I'll talk about that on my next slide. But for the destinations, which destinations do you have legal requirements for? There are actually two lists to check. There are countries that kind of think about where they go, we actually in our country are endemically at higher risk of TB, of yellow fever. So everyone who arrives in our country, you need a yellow fever vaccine. Then there are countries that worry more about where have you been before you've arrived in our country? Have you brought yellow fever to our country? So there are actually two slightly different lists. Where I tend to go is actually US CDC. So even though US CDC, under the current government, people have certain doubts about the US CDC, their country specific pages are still really, really good. And I tend to go to their country specific pages. And remember that it's not just entire countries, but sometimes also parts of countries as well. And unfortunately, the enforcement of that legal requirement actually depends on the person who's working at the border on that day. So some customs and immigration official will wave you through, whereas others will go, no, that's not good enough. We won't let you in. So that's also something to be aware of. Then destinations with higher risk of yellow fever, again, check the US CDC yellow fever maps. Then activity factors, so spending long periods of time in domestic settings without air conditioning, which is a deterrent for the Aedes mosquitoes that carry yellow fever. Then international legal requirements. There are international legal requirements to have the yellow fever vaccination documented in the yellow book that you may have seen by an accredited provider. But my tip is to make sure that you copy everything from a patient's yellow book into their digital records in the air as well, because yellow books get damaged, get wet, get lost in travel, and so you do want that digital proof as well, so you can issue them a new yellow book if they no longer have their existing yellow book. And then patient factors, so long-term frequent travelers. Again, it's one of those good investment vaccines, and also those who get bitten by mosquitoes a lot, and then people who are at higher risk of yellow fever adverse events. So these are the people who you may not want to consider yellow fever vaccination for. So people who are immunocompromised, young infants, people who are pregnant and breastfeeding, and old adults. So they're actually at high risk of yellow fever adverse events from the vaccine. And so you may actually want to be a bit more cautious with the vaccine. So for people who are at high risk of having yellow fever adverse events, if they're traveling to a destination where there's only legal requirements to get the vaccine, then you can just give them a waiver letter and go, as a doctor, I don't recommend them to have the yellow fever vaccine. They are waived from the vaccine. If they're traveling to a destination that is at higher risk of yellow fever, then you may need to kind of have that careful risk-benefit discussion with them and explore whether their itinerary needs to be changed to avoid the particular parts of a country that are at particularly high risk of yellow fever. So that's whether or not there's legal requirements, just any destination with higher risk of yellow fever. So I know that we're running very, very close to time. So just very quickly touching on vaccines outside of TGA registration, you can still access them with a bit of jumping through hoops. So there are a couple of different schemes. But it is, you do have to factor in the importation time, and it is at the traveler's own expense. And you may want to just refer them to a travel medicine clinic that has a lot of experience in organizing some of these rarer vaccines that you can't access immediately. Dengue, I put lots and lots of asterisks next to, because again, come October, I think we will be getting, I am told the Qdenga vaccine, the new dengue vaccine, will be arriving in Australia, and so there will be a ATAGI guidance to coincide with the arrival of the new vaccine. So please look out for that. Again, that's also being debated just by ATAGI next week. So again, I can't preempt what the advice will be at today's webinar. So please just look out for updated guidance from ATAGI. And then the single asterisk are things that I've discussed before. The little hat symbol for malaria, it would be very, very difficult for you to access malaria even through a vaccine, even through these schemes. So that it's for a very, very specific risk group of young children living in sub-Saharan Africa. So you've got someone who's moving to sub-Saharan Africa with a young child. You're better off referring them to a specialized travel medicine clinic to talk through all aspects of that kind of relocation. So in conclusion, just to say what happened with this patient. So sorry, so it was in 2017, so not 2019. In the end, we actually went with a dose of DT because he was just he's seen his colleagues get tetanus shots when they've been injured at work. So that idea was just the most acceptable to him. And that was something that we had available at the clinic fridge. We didn't have to send him away to the pharmacy. We just give it to him straight away. But the anticlimax is that I no longer work at that clinic, and he apparently came back from the trip. Our practice nurse saw him at the local supermarket, but he didn't actually. So he did come back from that trip safe and sound, but he didn't come back to get all his other catch-up vaccines. So there went my nice plan to get him all caught up after he came back. That didn't end up happening. But yes, so that's the end. So here's some resources for you, just some reminders again, take a good history. Yeah, there are lots of other important preventative measures in terms of behaviors to reinforce to travelers. Make sure that you check that they're up to date with the NIP vaccines as well as those more exotic vaccines. Enter non-NIP vaccines into the air as well. It's not mandatory, of course, to enter travel vaccines into the air, but it's so useful because nobody remembers what travel vaccines they got 5 years ago. So yeah, so there you go, and some references that I use, and hopefully we've got our 5 minutes for questions.
Thank you very much, Annie. That was really interesting. I love VFR. That'll become part of my notation. We've got some questions. For people in the Central West, how strongly would you advise getting the Japanese encephalitis vaccine?
Um, so I guess if you are living in that kind of recommended area from New South Wales Health, and if you're also going to be traveling, if you're also undertaking camping and all of those kind of high risk activities locally, then I definitely go look. You've ticked off all of these things on my list of risk. I would recommend it, but. I guess it's really about that conversation with the patients going, there's these kind of mental checklist of risk factors I have. You meet all of these. So I would suggest that you get it. And if you can actually get it for free, if you meet some of those other eligibility criteria, then why not, but clearly, it really depends on all of these other things. Yeah.
And a specific question about MMR. If a patient missed MMR vaccine at year 7, do we need to vaccinate them anytime if they accept or not?
I'm not sure what you mean. So, I mean, if they don't accept the vaccine, then clearly we can't vaccinate them, obviously. But um, do we vaccinate them any time? So if they miss their school-based dose, and if they come to you as a GP, then you are definitely able to catch them up as a
Yeah.
GP.
Yeah.
Yeah.
Yep, sounds good. And is doxycycline still a good basic treatment for malaria prophylaxis?
Yeah, so do check out so when you kind of think about malaria prophylaxis, I know it's kind of outside the scope of this talk, but do also check out some of the maps available on US CDC as well in terms of resistance patterns. So doxycycline in the right part of the world is still recommended.
Excellent. We don't have any more questions in the chat box. Just if anyone would like to unmute and ask a question. Otherwise, we might be finished, and therefore I really want to thank both of you, Victor and Annie, for a really interesting discussion about rabies, Lyssavirus, bird flu, travel. It had everything. So, yep, thank you very much. And just a reminder for everyone else to fill in your evaluation. That's
Thank you.
good.
Thank you, everyone, for joining us
Thank
tonight.
you. Thank
We look
you.
forward to getting your
Bye.
feedback. Thank you.
Yep. Bye.
Thanks, Jenny.
Thanks, Erica.